alter the classification of 2 and 3 stages more accurately, and you will reclassify the patient from either a higher to lower or lower to higher, changing his prognosis significantly. So whenever you have a borderline GFR close to 60 and you want to reclassify the patient whether he is having stage 3 CKD or he is in stage 2, then cystatin becomes very important. It's not affected by muscle mass is the main advantage. We know the reference ranges. Of course, you know that we cannot use creatinine in amputees or diseased patients, malnourished patients and things like that. Now, when I included uric acid today, the idea was to tell you that we see uric acid in cases of gout, metabolic syndrome, chronic kidney disease, leukemias, drugs like pyrazinamide, but all of us are not aware of uric acid as a risk factor for other things. Just like cholesterol is a risk factor for cardiac diseases, for strokes, uric acid is an independent risk factor for heart failure, for left ventricular hypertrophy, for stroke risk, and there are enough studies to show that treatment of uric acid with allopurinol or other compounds have reversed the left ventricular hypertrophy. So it's also a risk factor for metabolic syndrome. So when we talk about uric acid, we should keep in mind that apart from denoting all these conditions, uric acid also acts as an independent risk factor for all cardiac risk, stroke risk and other conditions. Low levels of uric acid seen in these conditions. There is again enough data to show that uric acid is an independent risk factor in young children with hypertension. There are published papers to show that just uric acid lowering has resulted in normalizing the blood pressure in young adolescent. In adults it doesn't happen. But that's why uric acid is getting increasing importance. In between 2010 to 2014, you will see a lot of papers on uric acid lowering resulting in halting kidney disease progression. See, barring ACE inhibitors, we have nothing to stop a progression of diabetic nephropathy. But if we lower uric acid in these patients, there is slower progression of the renal disease. These papers have been published from 2010 to 14. The only reason we don't do it commonly is because allopurinol is not a safe drug. You know, it produces Stevens-Johnson syndrome, it can produce bone marrow suppression and agranulocytosis. So we don't use as a preventive drug. Now when we are talking about diabetes, I would just, all of you know this, but you will be surprised whenever I am taking any interview for candidate, and when I ask them what is the normal value of fasting blood sugar, I get an answer 70 to 110. Then when I ask them that what is impaired glucose tolerance, this is quoted differently. So it's important to know that these are the latest criteria. 2-hour post glucose is 140 is normal, 140 to 199 is impaired glucose tolerance, and above 200 is this. Now all of us were aware that glyco-HB was always a prognostic criteria, but glyco-HB is now a diagnostic criteria. So above 6.5 grams, we would call it as diabetes mellitus. These are ADA guidelines 2013 now. Between 5.7 to 6.5, we will classify as impaired glucose tolerance. Less than 5.7 is normal. This is a very interesting case. I hope you pay attention. This is a patient which is 65 kg, BMI is normal. He is on oral anti-diabetic drug. The fasting blood sugar is totally uncontrolled. It is 210. Glyco-HB 8.9. Now look at his other parameters. Triglyceride, absolutely normal. HDL cholesterol, high normal. Uric acid, absolutely normal. So a person with no metabolic risk factor, he is not your usual metabolic syndrome patient because he has normal triglyceride, high HDL, you know what is the definition of metabolic syndrome? Waist circumference more than 40, blood pressure more than 130 by 85, impaired glucose tolerance, that means your fasting sugar between 100 to 126, and your HDL cholesterol less than 40. Your triglyceride more than 150. Out of these 5 criteria, any 3 being there classifies it as metabolic syndrome. Now this patient is not fitting into it. So what would you suspect then? Okay, if I give you one more information that he has a low C-peptide, then to me the diagnosis is very clear. That's why I am asking you. That's why I kept this information. So he is a non-metabolic syndrome patient, not getting controlled with oral anti-diabetic drug, normal BMI, C-peptide absolutely low. So he is a case of latent autoimmune diabetes in adults. In India, about 15% incidence of LADA. So you can't afford to miss it. LADA, to begin with, will have a normal C-peptide, but the progression of beta cell exhaustion is much faster compared to a normal type 2 diabetes because of autoimmune origin. These people will also have insulin antibodies, GAD antibodies. So important to remember. Then we come to urine for microalbumin and creatinine. This again, when I ask somebody that what does it denote? When you do urine microalbumin create, what does it tell you? The answer is, it tells us the risk of kidney damage. It's an early marker for kidney damage is the universal answer. That is not right. It's a vascular dysfunction marker. It's a marker for endothelial dysfunction. Most of the patients with microalbuminuria would die of heart failure, stroke or cardiac events and not of renal failure. Kidney is enjoying 20 to 30% of body's blood supply. 24% is the average blood supply. Large amount of vasculature, and that's the reason the endothelial dysfunction gets reflected in the kidney more easily, but it doesn't mean it is restricted to kidney. This endothelial dysfunction is across all the blood vessels. So be it be in heart, be it be in brain. So that's why it's a risk factor for all vascular dysfunction. Please remember that. So it's a risk factor for diabetes, it's a risk factor for hypertension. In fact, if you see obese children have about 12% incidence of microalbuminuria without hypertension or diabetes. Why? Because the adipocytes have inflammatory cytokines which are produced in them and they cause microalbuminuria in these people. And once they lose weight, the microalbuminuria in young children is reversible. Okay? So, all of us know that the normal range for microalbuminuria is 0 to 30. I have already discussed that it's a risk for vascular anomalies. Now again, there is an impression that if we reduce microalbuminuria, it is good and that means the outcome is good. Is it true? To some extent, but not always. Please remember that this is a surrogate marker. I will give you the reason why always microalbuminuria reduction is not good. Suppose I put the patient on some ARB drug, say telmisartan, and ACE inhibitor, ramipril. It will bring down microalbuminuria much more than if I use a single drug. But there are many studies to show that these patients, the last one is on target. There is a study called Altitude where direct renin inhibitor is combined with a receptor blocker. So the ACE inhibition is blocked at 2 levels, will result in reduction in microalbuminuria, but with poorer clinical outcomes, and these patients will actually do badly. So lower the better is not always true for microalbuminuria. It also how the reduction is achieved. So that's the risk of using a surrogate marker. Why it is important? Because people started claiming that reduction of microalbuminuria is reflective of protection from kidney damage. So the trial which destroyed this myth is called a trial called Accomplish trial, where an ACE inhibitor and amlodipine, an ACE inhibitor and diuretic, were the 2 arms. ACE inhibitor and diuretic arm showed more microalbuminuria reduction but poorer renal outcomes. This study was done in 2010 in 12,000 patients. After that, all nephrologists now consider that reduction of microalbuminuria is good, but it's a surrogate marker, and how that reduction is achieved is equally important. Just on paper, reducing microalbuminuria doesn't change the patient clinical outcome. So aggressive multiple drug medical therapy to reduce microalbuminuria is not advised. The newer guidelines say that ACE inhibition at more than one place. So you cannot combine a direct renin inhibitor with a S blocker. So that is the latest guideline. So please remember that. This is a case which is very interesting. You will see it in your day-to-day practice. This is uncontrolled hypertensive, usual patient. Microalbumin create was high. Uncontrolled diabetes, we see it all the time that most common cause of microalbuminuria is a diabetic nephropathy. Creatinine is still maintained. So according to us, this is an early stage of diabetic nephropathy. Urine microalbumin create is still 90. So this patient is treated. He comes for follow-up. I see his BP is absolutely normal. Glyco-HB has come almost closer to normal. Microalbuminuria creatinine ratio has now become from 90 to 18. This is the actual case in our lab. Create has gone up from 1 to 1.3. So what are the possibilities? His diabetic nephropathy is worsening. Serum create has gone up from 1 to 1.3, means he has lost 30% of his GFR. So what would you say? I would say the second, that this patient is responding to treatment. What has happened? All his metabolic parameters have become normal, including microalbuminuria create ratio. A 30% elevation in create is a hemodynamic adjustment to lowering of blood pressure, and because this patient is obviously put on ACE inhibitor by the diabetologist, that's why his microalbumin create has come down dramatically. So this is a hemodynamic adjustment that the create has gone up, and there are enough studies to show that patients in whom there is an initial rise after controlling the risk factors are the ones who do the best in terms of kidney disease progression. So if you stop medication for these patients, they would do very poorly compared to a normal person. So this patient is responding very well to his diabetologist or nephrologist treatment and not actually worsening. Then we come to prostate markers. All of us were aware of PSA. Now, why do we need another test for prostate cancer marker? You know that it's one of the commonest cancers in males. What is the reliability of PSA? If I wanted to ask audience, what is the reliability of PSA? Sensitivity, specificity? The answer is less than 50%. Then some of you will say PSA and free PSA ratio, because that is what we are taught. What is the reliability of free PSA and PSA ratio? Less than 50%. So insurance reimbursal for PSA as a marker and to do biopsies on the basis of PSA is stopped. What is the answer? So we are trying for multiple answers. PSA still plays a role. But remember, PSA is expressed by all prostatic cells. So if somebody comes with a very large prostate weighing 60 grams, his PSA is going to be 5.8. It's not because of cancer, but because of size of the prostate. We all know that prostatic infarction, inflammation, infection, indwelling catheters, digital rectal examination, having a sex, all this can cause temporary PSA elevations. So we look for a better marker, and the better marker was thought to be, we are through?
Sir, we are time out, sir.
Okay. So this is the last slide anyway. Now we have a new assay called a PCA3 gene test, which is done on the urine. But the best sensitivity and specificity for prostate cancer is the new test which has come in 2014. These two scientists had an accuracy rate of 99 to 97% for prostate cancer detection. And these scientists were capable of identifying it on each and every occasion. Now these two scientists were German shepherds and they actually could detect with 99.9% specificity and sensitivity. This paper was published in American Journal of Urology and the AUA Congress in May 2014.